It is my pleasure to introduce today's presenter, Dr. Iweala, an associate professor of medicine at the University of North Carolina and director of the UNC Allergy Mast Cell Disorders Program. Dr. Iweala is part of the Division of Rheumatology, Allergy, and Immunology, and it is affiliated with the UNC Food and Allergy Initiative, Children's Research Institute, and the Thurston Arthritis Research Center. Thank you so much for joining us today.
Thank you so much for that kind introduction. As you guys heard, my name is Iweala, and I really appreciate this opportunity to talk with you guys about a subject that interests me tremendously and talk about it in the context of long COVID. So I will go ahead and share my slides and hopefully, let's see here.
It's looking good on this end.
You can. Okay, awesome. So then I'll go ahead and get started. All right, so today, what I'm hoping to do, let's see here. Okay, so you've already heard of my different disclosures. As was said earlier, they're primarily grants and then being on some advisory boards related to mast activation and alpha-gal syndrome, which is another passion of mine. But what I'm hoping to do tonight is to first define what mast cells are, then discuss how allergy immunology doctors define mast cell activation syndrome, and just identify diseases that are associated with mast cell activation versus confirmed MCAS, touch a little bit on what we know in terms of epidemiology of mast cell activation, and then talk about the triggers of mast cell activation and degranulation, because I think this is where COVID-19 and long COVID fits in. And then talk about some of the management challenges that we face with mast cell activation. Okay, so let's get into it. What are mast cells? So mast cells are actually innate immune cells, and they're really large, and that's what's demonstrated in the scanning electron micrograph that you can see on the left side of the slide. So they can be up to 20 microns in diameter, and they live in tissues throughout the body, but they're particularly enriched at the sites of the body that are exposed to the outside world. These include places like the skin, the airways, the gut, so basically mucosal linings and epithelial barriers. And the key thing to remember about these mast cells are that the progenitors or the precursors to mast cells actually arise in the bone marrow. And so, what this schematic is trying to demonstrate is that once these mast cell progenitors are produced in the bone marrow, they migrate to the tissue where they're going to mature. And so, because they migrate to so many different tissues and there's so many different types of microenvironments within those tissues, it results in a lot of heterogeneity in mast cells because how the mast cell evolves or develops or behaves depends on the type of microenvironment that it finds itself. But despite the heterogeneity across these mast cells, there are a few molecules that we use to identify all mast cells. So one of them is called CD117 or c-KIT, and this is actually a surface receptor that's a tyrosine kinase, and it binds to this molecule called stem cell factor or SCF, also known as KIT ligand. And so you're basically diving in with me into this wonderful world of immunology where we have like 3 or 4 or maybe more different names for the same receptor. So apologies for that. The other thing that mast cells possess is this receptor called CD123, also known as the interleukin 3 or IL-3 receptor, and it binds to this interleukin. And the reason why these two things are important are because these two cell surface receptors bind to the molecules, stem cell factor and IL-3, that mast cells need in order to grow and be maintained within the tissues. We don't know exactly how long mast cells live in the tissues, but based on animal studies, like rodent studies, we think the half-life of these mast cells in the tissue is about 40 days. So the key thing to remember about mast cells is what I said earlier. They're innate immune cells. So that means that they're critical for host defense, and they can play key roles in generic non-antigen specific immune responses as well as in antigen specific responses. So they serve as sentinels in host defense against pathogens and foreign bodies. So these can classically include things like helminths or worms, but they also are important for combating viruses, bacterial infections, fungal infections. They also respond to toxins and venoms. And then in the context of allergy or allergic disease, they respond to allergens. And these are generally food or environmental aerosolized allergens or aeroallergens. And the way that these mast cells can participate in these types of immune responses is because they actually have these special docking stations or receptors on the surface that are called IgE receptors. They're able to bind immunoglobulin E or IgE that's produced by B cells. And once the IgE attaches to the mast cell is now capable of driving what we call allergic effector mediated symptoms in response to specific types of allergens. And when a mast cell gets activated, there are actually three different ways or three different buckets of inflammatory mediators that it can produce. So I'm showing you here a schematic of the mast cell, and you can see that as soon as the mast cell gets activated, the things that are immediately released in these granules, represented by these teensy circles that are ordinarily inside the cell and get released upon activation of the mast cell, these include chemicals like histamine, the enzyme tryptase, as well as other cytokines and proteases. And I emphasize histamine and tryptase because you'll see later on they're important in terms of diagnosis and management of patients with mast cell activation symptoms. However, mast cells can also synthesize new chemicals over the course of minutes, and they usually synthesize these chemicals from lipids or fats that are found in their cell membrane, and they produce chemicals like prostaglandins and leukotrienes from these lipid cell membrane lipids. And then finally, over the course of hours, an activated mast cell can actually transcribe new genes. Those new genes then get translated into mRNA and into proteins, and these include cytokines like IL-4, IL-5, IL-6, IL-13, and more TNF-alpha. So basically, cytokines associated with allergic responses or with inflammatory responses. So now let's get to this question. How do allergists define mast cell activation syndrome? And I say very specifically allergists because depending on who is providing the care and who's taking care or trying to diagnose someone with mast cell activation syndrome, there are different understandings of what symptoms or criteria, comprise mast cell activation syndrome. So this is very specifically how allergy immunology doctors define mast cell activation syndrome. So to have a confirmed MCAS diagnosis, you need to have three components. The first, you need to have typical symptoms that go along with mast cells going wild. Secondly, you need to have some evidence of positive lab tests that are consistent with mast cell activation. And third, when you take medicines that either stabilize the mast cells or block the chemicals that mast cells make from actually having an effect, you get some sort of improvement in the symptoms that you're attributing to mast cell activation. And I'm going to go through each of these in more detail in subsequent slides. So I'll just put out there that there's a lot of controversy, even within allergy immunology or hematology oncology, which are classically the specialties that end up seeing patients who are worried about mast cell activation. So much so that there have actually been a couple of consensus conferences to come up with consensus guidelines for the diagnosis and management of mast cell activation syndrome. And so a lot of what I discuss in the talk comes from this consensus guideline from 2019 from the Quad AI, specifically about how to diagnose MCAS and recommendations for management. So let's dig into these three criteria that I mentioned earlier. So number one, what do I mean by typical symptoms? So typical symptoms mean symptoms that are classically associated with mast cell mediator release, like what you would see in a standard allergic reaction to an environmental allergen or food proteins. And so you can see examples of what the consensus guidelines include in this table. And so you can see that it's specifically at least two out of the four organ systems that are listed in this table. So cardiovascular, respiratory, dermatologic, and gastrointestinal. The other thing I'll say is you can see it's very specific types of symptoms under these buckets. So I'll highlight that with dermatologic and gastrointestinal in particular. So you can see it's for dermatologic or skin, it's not things like eczema. It's things like flushing, urticaria or hives, pruritus or itching, and then angioedema or swelling. And the idea is when a mast cell is activated, the type of response it's trying to generate is a response that wants you to get toxins out or away from the body. So flushing, urticaria, itching, they make you want to scratch, and get a parasite off. Similarly, for the GI symptoms, you'll notice constipation is not in that bucket. It's things like diarrhea, nausea with vomiting, crampy abdominal pain. And again, a way you can conceptualize this is that if it's mast cell driven, the idea is this is a toxin, this is a danger signal. I need to do something to get it out. So diarrhea, you're pooping it out. Nausea with vomiting, you're vomiting it out. And so those are the types of GI symptoms, for example, that we're looking for. The other ones, low blood pressure, fast heart rate, syncope or near syncope under cardiovascular, and things like wheezing, shortness of breath, inspiratory stridor, as well as upper airway symptoms that aren't listed here. So sneezing, itchy nose, itchy ears, nasal congestion. And then one thing I will highlight is that these are the symptoms that we believe are the most predictive of mast cells being involved. The pretest probability that a mast cell is driving these symptoms is high with these particular symptoms. That doesn't necessarily mean that patients that deal with mast cell activation symptoms don't have other organ systems that are effective. It's just which ones do allergy immunology feel are helpful for diagnostic value. Again, this is just to demonstrate that there's not always consensus in every single symptom that we think should be attributed to mast cell activation. So this table shows a list of symptoms that were thought of during the 2012 consensus meeting, and then the consensus level across these. So they included symptoms that had at least 70% consensus. And then just to emphasize that many times people who are dealing with symptoms of mast cell activation have a whole host of other conditions that they're also managing. And one thing I just want to point out is that these symptoms, even though they frequently or can run alongside symptoms of mast cell activation, these symptoms are not specific enough to be considered of diagnostic value by allergy immunology doctors when we're trying to figure out, okay, are mast cells driving the problems for this patient? And so I highlight things like fatigue or joint hypermobility, hypermobile Ehlers-Danlos syndrome, POTS dysautonomia, so postural orthostatic tachycardia syndrome, autonomic dysfunction, constipation, neuropathic pain, and multiple chemical sensitivities, because these are often running alongside people who are dealing with more conventional symptoms of mast activation, but they're just not specific enough at this time for us to know that mast cells are the primary driver for these symptoms. So then moving on to the next criteria, so to speak, that we look for, does the person have any evidence of lab tests that are consistent with increased mast cell burden, mast cell degranulation, or mediator release? So the gold standard that allergy immunology doctors and hematology oncology doctors look for to look for overactive mast cells or too many mast cells, so high mast cell burden, is the serum tryptase. And so if at baseline, a person's serum tryptase is 20 nanogram per milliliter or higher, your pretest probability for a clonal mast cell disorder, so your suspicion that some sort of mutation is driving the mast cell disease, goes up. And those are people that you want to refer to hematology oncology for bone marrow biopsy with the question, is this systemic mastocytosis? There are also individuals, though, who have tryptase levels at baseline that are 8 nanogram per mil or higher. In that case, they may not necessarily have a clonal mast cell disease, but they may have a genetic trait called hereditary alpha tryptosemia syndrome that can be in people who have both clonal mast cell disorders or non-clonal ones, but this trait seems to be linked to the severity of mast cell activation and the likelihood of a person having anaphylaxis. So when we collected tryptase, the reason we would do so is we're talking to the patient, we're getting a history that makes us suspicious. You know, we got the symptoms, at least 2 organ systems at the same time within those ones I told you about, alongside the additional things the person is worried about. So we're like, okay, let's get a serum tryptase. When's the best time to get this? So you get the baseline one, but really we're also looking for the tryptase during a flare. And ideally, we want to collect it within 4 hours of the start of the flare. And when we get that tryptase, we want to see, number one, is it abnormal? And if it's abnormal, okay, that we've got a confirmation something's going on with the mast cell or mast cell burden, but it may actually end up still being normal. So in that situation, you want to compare the tryptase collected during an acute symptom flare with the baseline tryptase. And there are formulas that you can use to see whether the increase in the tryptase level is sufficient to say that it confirms mast cell activation syndrome. Now, it's difficult to remember some of these formulas, so the other thing you can do is head to the NIH anaphylaxis tryptase calculator, which is this website here. And if you do so, what you'll find is you can actually just pop in what the baseline tryptase is. You can pop in the acute tryptase measurement. You can put in your pretest probability, like what is your suspicion that you think this person has mast activation syndrome? And then it will plot, the ratio. And if it's above or below the line, that lets you know whether or not you have a diagnosis of anaphylaxis or confirming your mast cell activation syndrome. And then why is it that we keep emphasizing, please, please collect the blood, within 30 minutes to 4 hours of the symptom flare to really be able to see a tryptase? And this diagram really helps demonstrate that. So here I'm showing you the tryptase concentration on the y-axis, and on the x-axis is time in hours. And what I hope you can appreciate is this is the person's baseline tryptase to begin with. They get exposed, they have some sort of anaphylactic event. And you can see that within the first 2 hours is where you really see the peak in the serum tryptase level. And after that, it starts to decline. And so that's why we really want to try our hardest if we can to get this tryptase in this window. Otherwise, if we're starting to collect it out here, a day later, we're probably going to miss when it was truly elevated, and then we may not get a diagnosis that's confirmed. However, we recognize that it's really challenging to be able to tell a patient who's in the midst of having a severe allergic type reaction to say, head to your emergency department or wherever and ask them to draw this tryptase. So another strategy that we can use is to do 24-hour urine collections. And in some institutions, they have access to spot urine collection. So, and we look basically for the breakdown products or the metabolites of these mast cell mediators accumulating in the urine. If you have access to the spot urine that's usually sent out to Mayo Clinic, again, they'll ask you to collect it within 4 hours of the acute symptoms. If you don't have access to that, most of the time, and what we do at UNC is the 24-hour urine collection. And again, we're looking for these N-methylhistamine, 11-beta-2 prostaglandin F2, urine leukotriene E4, again, breakdown products of mast cell mediators in the urine to confirm that when the person was having the symptoms, mast cells were overactive. And then just to emphasize that, again, there's controversy when it comes to what mast cell mediators constitute confirmatory mast cell mediators. And there's some literature that's looking at things like heparin or serotonin or chromogranin A as potential things to use as confirming mast activation. Right now, because there are other cells that can produce these factors that are over here on the right-hand side, at this time, these markers are not considered sufficient to confirm a diagnosis of mast activation. So if we get labs like these, we're also going to be looking for things like tryptase and histamine and breakdown products of these tryptase, histamines, and prostaglandins to confirm the diagnosis of mast activation syndrome. So then finally, the third criteria is when the patient takes a medication to try to deal with the symptoms, and really it's medications that fall under antihistamines, under mast cell stabilizers, under leukotriene pathway blockers. And, in the past, aspirin was also considered amongst these. I rarely use this medication, and we'll get into what I actually like to use later on in the talk. But if you get in your history that the patient feels better, they may not be completely cured, but if they can noticeably notice an improvement in their symptoms with these medications, that's the third criteria that we look for to say, okay, this is a confirmed diagnosis of mast cell activation syndrome. So then let me walk you through the way that I think when I have a patient in front of me and I'm trying to figure out, okay, is this confirmed MCAS or not? Because it leads me down different diagnostic pathways and different pathways for working up the patient. So if all three of these Quad AI 2019 guideline criteria are met, we say, yes, this is confirmed mast cell activation syndrome. And then we start trying to figure out, is this a primary problem where there's some sort of mutation that's directly messing up the mast cells, and that's why they're twitchy, overactive, or overgrowing? Or is this a secondary process where the person has some sort of allergic disease or some sort of other underlying condition that lowers the threshold for the mast cells to become twitchy and release allergic inflammatory chemicals? Or is this something that's just happening spontaneously and we can't identify a reason for it? If the criteria aren't all met, then we start going down this pathway and we start looking for additional symptoms. If there's no symptoms that seem specific for mast activation, we need to start broadening our differential diagnosis to think beyond MCAS. If there are symptoms that are consistent with mast activation, but they're not fulfilling criteria, we need to start thinking about, could this be evidence of localized mast activation, maybe just involving one organ system or one tissue, or is this some sort of disorder that seems to be associated with mast cell activation? So, as I mentioned earlier, you got confirmed mast cell activation syndrome. I talked about the primary or clonal mast cell disorders, including things like systemic mastocytosis or cutaneous mastocytosis with associated mast activation. For the things that are more secondary, they could be dependent on these immunoglobulin E, so conventional IgE-mediated allergies, or they could be driven by IgE-independent triggers of mast cells, which I'll get into in more detail later on in the talk. But things like autoimmune diseases can sometimes lower the threshold for mast cells to degranulate. You'll see I have some things italicized and in question marks because these are things that I think lower the threshold for mast cells to degranulate, but it's not yet 100% out in the allergy immunology literature. I think this is still stuff that's under investigation. In terms of going down the no pathway, so what do I mean when I say, okay, localized mast activation? By that, what I really mean is chronic spontaneous urticarian angioedema. And this is not uncommon in individuals who had an acute COVID-19 infection or some people who actually got vaccinated against COVID-19. You riled up the immune system, including mast cells, which are important for fighting off different types of infectious organisms. And for most people, after the immune system is riled up, it calms down appropriately. But for some people, the mast cells in the skin remain riled up. And in that situation, people can develop spontaneous hives and swelling. So that's one example of localized mast activation. Similarly, there may be individuals who have increased numbers of normal-looking mast cells found in different areas of their gut. They may have problems with a lot of abdominal cramping and diarrhea, but they don't seem to have a lot of problems anywhere else. Like they're not complaining of hives or swelling or difficulty breathing or passing out, but they have a lot of cramping and diarrhea and they get this biopsy. So in those cases, that might be localized mast activation in the gut or mastocytic enteritis. And then in this corner over here, disorders associated with mast activation, this is where things like viral infections or COVID-19 or post-viral or post-infectious syndromes like long COVID, virus-induced autoimmunity, autonomic dysfunction, again, in my opinion, or collagen disorders. These are conditions where, at least in my clinical practice, I seem to see a lot of evidence of symptoms of mast activation that may not necessarily match with all the biomarkers. So the testing doesn't always come up positive, but people seem to have these symptoms. Okay, so now let's transition a little bit into the epidemiology of mast activation. So who all are the people that are coming in worried about these types of symptoms, at least in my allergy immunology practice? So in my practice, and again, this is just data over an 18-month period from January 2019 through June of 2020. We found that 90% of the patients that came in concerned about mast activation symptoms were female, or at least born female. They may have been transitioning or may be non-binary, but were assigned at female at birth, whereas only 10% were assigned male at birth. Similarly, in terms of self-identified race and ethnicity, about more than 80%, so 87% identified as white or Caucasian, and basically less than 4% identified as Black or African American, other race, which was where Hispanic tended to be clumped into that. And then in my practice, less than 1% Asian, less than 1% Native American or Alaska Native. And again, this is just who has access to come to the UNC Allergy or Immunology Clinic. It may not be reflective of who's actually impacted by this condition. If we look specifically amongst those patients that actually met all three criteria to be diagnosed with confirmed MCAS, about 11% of patients coming to my clinic during this 1 year period met that criteria. About 90% were what we would say are biomarker negative mast activation. So meaning they have symptoms of mast activation, but we can't technically call them confirmed MCAS because they don't meet all the criteria. But even when you look at those 11% of patients that met criteria for confirmed MCAS, the sex distribution still matched the sex distribution of all comers who were concerned they had mass activation, and very similarly in terms of the self-reported race and ethnicity as well. What about age distribution? So basically, I'm primarily an adult clinic, but I do see some adolescents, and people of all ages are coming concerned about mast cell activation. You can see a couple of peaks around, 25 to 30 and maybe around 50s or so. But really, people across the spectrum are coming in concerned about these types of symptoms. And when we looked at de-identified patient records over a 4-year period from 2015 to 2019 in the UNC Health database, we looked at over 5 million patient records, and we just looked for diagnoses codes like mast cell activation syndrome, mast cell disorder, idiopathic anaphylaxis, basically codes that are used when patient providers are worried or working up potential mast cell activation. And we saw that the prevalence of this more than doubled over that 4-year period, as you can see in the graph on the left-hand side. And then interestingly, when we looked at years that included the onset of COVID in the United States, and this time we looked at de-identified patient claims from an IBM market scan database, what you can see here is if you look at this teal blue line in particular, this diagnosis code represents unspecified mast cell activation. So it's a popular diagnosis code that's used when people are suspicious or trying to work up some sort of mast cell disorder, but they don't necessarily know if it's confirmed or whether it's clonal or non-clonal. You can see that the other types of mast cell diagnosis codes, they rose a little bit, but they generally plateaued between 2017 to 2022. By contrast, this unspecified mast cell activation, it was already on the rise before COVID. But if you take a look at the slope of the line between 2020 and 2021, you see that it starts to increase a little bit. So, what about mast cell activation and quality of life? So what you can see here is survey data taken in 2014 by the Mast Cell Disorders, or TMS. It was the Mastocytosis Society, now the Mast Cell Disorders Society. And they basically asked patients, what's the impact of mast activation on your quality of life? And you can see that it had a pretty incredible emotional impact on patient life. 40% saying extremely, 35% saying moderately, so a total of 75% of people with a moderate or extreme impact of mast activation on their lifestyle. And when they asked about the greatest distress-causing aspect of living with this condition, it's the symptom unpredictability, the gastrointestinal symptoms, and the inability to work or perform activities of daily living. So why would mast cell activation occur then in the first place? So to try to get at why, non-clonal mast cell activation might happen, we have to think beyond clonal mutations. So as I've mentioned earlier, if there's a mutation in the mast cell that messes up the way the mast cell grows, aggregates, its shape, the kind of activation markers it expresses, it makes intuitive sense that those mast cells would be more likely to release allergic inflammatory chemicals and cause problems. But what about when the mast cells don't seem to have any mutations, are perfectly normally shaped? Maybe there's a few higher numbers of them maybe located in certain areas, but they look pretty normal. So I think one way that we can try to explain this is the fact that even though as allergy doctors, we focus a lot on the IgE receptor and IgE and allergens driving mast cells to be activated, this schematic demonstrates that mast cells can express all sorts of receptors. Receptors for different types of microbes, receptors for inflammatory signals. There are receptors that drugs can actually, like medications, can actually bind to directly, including opiates. There are receptors that can recognize neural peptides. Inside the cell, there are receptors that recognize sex hormones. They're histamine receptors. And so you can see that both IgE dependent and IgE independent immune triggers, as well as non-immune triggers, are capable of activating these mast cells. In addition, mast cells also express the ACE2 receptor, which is a receptor that is involved in SARS-CoV-2 entry. And there's also this question, like there's active investigation whether C-type lectin receptors that can bind carbohydrates, including those on SARS-CoV-2, could be responsible for COVID-19 viruses infecting mast cells. And then, as I had mentioned earlier, these are some of the non-immune triggers that can drive mast cell activation. So neurotransmitters, neuropeptides, hormones, growth factors, as well as physical or biological stimuli that can lower the threshold for these mast cells to become activated, release chemicals, and cause symptoms. On top of this, this is a schematic or cross-section of the skin. But the reason I put this up here is to demonstrate that mast cells, nerve fibers, and blood vessels are all very closely located next to each other, and they all sit within the connective tissue. So you can imagine if a nerve is disrupted or dysregulated, and it's in communication with a mast cell, they're very close by and they can communicate with each other and probably cause a disruptive cycle to ensue. So here's another schematic to try to illustrate that point. So this is a mast cell here, this is a nerve ending here, and basically it's just trying to show that neural peptides produced by the nerve ending can impact the behavior or activation of these mast cells. The mast cells in turn can produce chemicals that can interact with the nerve ending, and so they can sort of amplify different types of responses in the course of a mast cell activation flare. And so what are the types of triggers that can actually drive mast cell activation syndrome flares in individuals who have clonal or non-clonal mast cell activation syndrome? So again, this is a survey of these individuals, and they reported that heat, stress, exercise, alcohol, medication, odors, and insect stings were among the top triggers for driving a mast cell activation response. Interestingly, there has also been an association with mast cell activation disorders and small fiber neuropathy, as well as impaired cerebral blood flow and autonomic dysfunction. And again, this is going to be something that's very important in long COVID and chronic fatiguing illnesses, where autonomic dysfunction seems to be the name of the game, to be a large part of these conditions. So in the context of patients with confirmed mast cell activation syndrome or who have the genetic trait that predisposes them to have anaphylaxis, this HAT or hereditary alpha-tryptosemia, these patients actually underwent skin biopsy looking for small nerve fiber density, and they actually found a reduction in many of these patients consistent with a small fiber neuropathy. And then, like I said, they found impaired cerebral blood flow, which could go along with some of the central nervous system type symptoms that can sometimes be seen in patients with autonomic dysfunction. And then if we think about the immunopathogenesis of long COVID and some of the factors that we think drive these, things like overall immune dysregulation, the persistence of inflammatory responses, the possibility of having viral pathogen reactivation, disturbance or dysregulation of the host microbiome, cellular mitochondrial metabolic dysfunction. All of these things can act as danger signals to mast cells. Because again, mast cells are cells that are supposed to recognize danger, whether external or internal, and then release allergic and inflammatory chemicals to recruit additional immune cells to deal with the problem. And so the components that may be important in the pathogenesis of long COVID are also components that can lower the threshold of mast cells to be overactivated. And so I'm basically trying to show that here as well. So components that drive the immunopathogenesis of long COVID, there could be issues with nervous system dysfunction, which could lead to autonomic dysfunction. There's a growing body of research that suggests that the autonomic nervous system may be involved in a so-called anti-inflammatory reflex that's important for tamping down immune dysregulation in individuals who are trying to deal with infection or other autoimmune processes. And if that's not working properly, that too may be contributing to this form of immune dysregulation, mast cell activation. All right, so to wrap things up, let's turn to treatment. How do we go about managing patients who are dealing with confirmed MCAS or who are dealing with symptoms of mast cell activation, even if they're biomarker negative? So the primary line of treatment that we use are second generation H1 antihistamines. So the so-called non-sedating or non-drowsy antihistamines. You can see some examples of these over on the right side. They're really helpful for treating skin symptoms, itching, hives. I prefer these for daily maintenance therapy over the long term. And the key point is that you can tell patients to use up to 4 times the over-the-counter dose if they tolerate it. Again, if you increase the dose of antihistamines, you start to get more of the anticholinergic effect, so you may have more dry mouth, dry skin. Some people will have issues with emptying their bladder. So, if that's happening, reduce the dose. But for those who can tolerate it, we can push it right up to 4 times the dose. And for a lot of patients, that can be sufficient to get things to a manageable level symptom-wise. If not, we can also have patients take the first generation antihistamines. So these are the so-called drowsy antihistamines because they can cross the blood-brain barrier more so than the second generation. I try to save these for as needed use, but I will prescribe things like hydroxyzine or doxepin, which isn't technically an antihistamine, but has a lot of antihistamine properties. I will prescribe these, especially for patients that are not able to sleep through the night because they have a lot of problems with hives and itching. In addition, if there are patients dealing with mast activation symptoms who concurrently are dealing with a lot of pain type symptoms, so maybe deep bone pain or neuropathic pain, sometimes doxepin can actually be really helpful in that setting as well. And then they can also be helpful for dealing with gastrointestinal symptoms like nausea and diarrhea. And then if people are dealing with a lot of GI symptoms like abdominal cramping, diarrhea, may already be taking these H2 antihistamines to treat things like heartburn. And if they're dealing with symptoms of mast activation, these H2 antihistamines can also be helpful in that context as well. Primarily famotidine is what we've been using because ranitidine had been taken off the market for several years. It is now back, although it's prescription only. It's no longer over the counter. But in my clinical practice, I had found ranitidine to actually be more effective than famotidine. So once it's more readily available, I'll probably go back to recommending this. But famotidine, is relatively effective as well. I tend to stay away from cimetidine unless the patient comes to me on this because it interacts with so many of the other medicines that they may be using. And then there's the category of mast cell stabilizers. So these include in the United States, cromolyn, which is prescription strength, and it can be prescribed orally. You can get it topically to put in the eyes as cromolyn eye drops. You can have it nebulized for people who are having a lot of wheezing and breathing difficulties. And the trick with cromolyn is that it works where you put it. You don't really have a lot of systemic absorption of this medication for most patients. So I usually tend to use it for diarrhea and GI symptoms, but I definitely would prescribe it as a nebulizer. And the one place where you can buy it over the counter is as a nose spray. And so for patients that are dealing with a lot of odors as a driver for mast activation, sometimes stabilizing the mast cells in the nose using cromolyn can be helpful. And then you can use ketotifen, which is also, it has both antihistamine and mast cell stabilizing properties. In the United States, the way that we can get ketotifen is as an eye drop that you buy over the counter. There is very, very little ketotifen in the eye drop since you're supposed to be putting it in the eyes, and it works really well as an eye drop. But I've found that for some patients who are very sensitive to medications, you can microdose ketotifen by using ketotifen eye drops by mouth. But if a patient needs prescription strength ketotifen, in the United States, you really have to go to a compounding pharmacy. You're not going to find it in your standard commercial pharmacies, or the patient can go overseas. Like in Europe, Canada, Japan, those are places where some patients of mine have sourced prescription strength ketotifen. And then there are also, in addition to the daily chronic mast cell stabilizers, you can think of epinephrine almost as a mast cell stabilizer. It's the ultimate mast cell stabilizer that we save for emergencies. So when people are having severe acute mast activation flares consistent with severe anaphylaxis, in comprising symptoms that are described below, the way that epinephrine works is it actually can stabilize the mast cell and prevent degranulation for short periods of time. And then we ourselves make our own epinephrine or adrenaline. So kind of it's a pharmacologic dose until your own body kicks in to stop the mast cells from degranulating. There's injectable epinephrine, but just recently nasal epinephrine got approved. And so I find that for some patients who have needle phobia or who are very hesitant to use the epinephrine for severe symptoms, If they use the nose spray, that somehow kind of ratchets it draws it down a notch, and they seem more likely to use the emergency medicine when it's appropriate. And then finally, there are also medications that can block the leukotriene receptor pathway. So these are the so-called leukotriene pathway blockers like montelukast, also known as Singulair. There's zafirlukast, and then there's xyluton, which is a 5-lipoxygenase inhibitor. These are good if you have patients dealing with a lot of congestion and lower and upper airway symptoms. So there are also natural supplements that I found can be helpful in a lot of patients dealing with mast activation, especially those who are leery of adding on a lot of pharmaceuticals. So I kind of think of these as nutraceuticals. But again, there are no FDA-approved trials for any kind of treatment for the management of mast activation syndrome, and there are no FDA-approved trials in any disease for things like vitamin C, quercetin, diamine oxidase. However, vitamin C and quercetin in patients that tolerate them seem to act like a mast cell stabilizer. And so I encourage the use of these particular supplements in patients who would like to look at supplements as ways to stabilize their mast cells. And then diamine oxidase, I think of this more like the way that you would prescribe lactose for somebody who has lactase, rather, for someone who has lactose intolerance. It's essentially giving this enzyme, diamine oxidase, that's responsible for breaking down histamine and histamine-like compounds. And so a person can take it shortly before eating to try to break down any histamine-like compounds in food, and it helps to reduce some of the gastrointestinal and systemic symptoms of mast activation that they may be dealing with. And then finally, if all of those things are not sufficient, we start looking at biologic and small molecule inhibitors. And essentially, again, there are no biologics or small molecule inhibitors that have been approved for use to treat confirmed MCAS or symptoms of mast cell activation. But essentially, there are a lot that have been approved for treating things like asthma or treating things like hives and swelling. And so if you think of mast activation syndrome or mast activation along the spectrum of severe hives and swelling in places beyond the skin, not sufficiently controlled by high-dose antihistamines, you can justify using these types of biologics as an allergy doctor to treat patients dealing with these symptoms. And omalizumab or anti-IgE is the most common that's frequently used. It's the one where there's actually a clinical trial that was done in France that showed that patients with confirmed MCAS seem to get benefit from using the anti-IgE. But there are other molecules here, things like blocking direct mast cell degranulation and so forth. So I won't go through this. This basically summarizes in a table the different categories of medications that you can use to try to treat mast activation. But I will say that when you have individuals who just cannot get their symptoms under control, even though they're maximizing their mast activation medications and supplements, I will turn to immunosuppressives, so things like prednisone. Again, this is useful in the short or medium term. It's not a great long-term medication. And if I'm finding that I'm giving 3 prednisone tapers over the course of a year to try to manage these refractory symptoms, I start discussing with the patient the use of some of these steroid-sparing immune suppressants. And this is where an allergist would be very helpful in helping to manage the patient or give advice on how to manage the patient if they're not responding well to the other medications mentioned. So, as many of you may have experienced, the current therapies that we have for mast activation symptoms are rarely 100% effective, and it's really common for people to be on a bunch of different medications. And like I mentioned, there are tons of medications on the horizon for urticaria or asthma or food allergies or eczema or systemic mastocytosis, but there are none that explicitly target non-clonal mast activation. And I think part of the problem is that there's no patient-reported outcome measure that people can use in clinical trials to see the impact that their therapy might be having on the patient's symptoms. And so that's one of the research interests in my lab, is to try to develop some sort of patient-reported outcome measure that can help patients track their symptoms, before they start a therapy and then while they're on a therapy. And so this is something that's ongoing. It's not really ready for prime time, unfortunately, but we're working on it. So Let's summarize. Take home points from this talk. So, mast cell activation syndromes, as defined by allergy immunology doctors, we look for typical symptoms, so episodic symptoms that are superimposed on chronic symptoms, or they can just be episodic symptoms on their own, that are consistent with mast cell mediator release, and they affect two or more of those four organ systems: skin, gut, airway, and the cardiovascular system. Secondly, we want the patient to respond to drugs of some kind, so antihistamines, mast cell stabilizers, leukotriene blockers, etc. Or three, and then three, when they're having the symptoms of overactive mast cells, if we check they have an elevation in their tryptase level or an elevation in the mast cell mediators or their metabolites in the urine, or at baseline, their tryptase levels are abnormal. And then remember that not all patients with mast cell activation will have confirmed MCAS. Most likely they have some other underlying disorder, and it could be long COVID that's associated with mast cell activation. So that's what we're trying to demonstrate here with these Venn diagrams in the schematic. So with that, I just want to acknowledge my colleagues that are part of the UNC Allergy Mast Cell Disorders program. I'm very proud of the fact that we're part of the American Initiative in Mast Cell Diseases. And again, acknowledge all the members of the program that have helped in terms of research, members of our allergy immunology clinic, especially the nurses and our allergy immunology fellows who are essentially on the front lines, helping to take care of patients dealing with symptoms of mast cell activation. So with that, I thank you so much for your attention, and I'm happy to take any questions.
Thank you for being so comprehensive. It was really great to hear everything that we have a lot of people who have discussed and talked about mast cell before, but this really helps us kind of define mast cell activation syndrome and then mast cell activation, which often confused a lot of our clinicians on the call. So this helps us kind of. So one of my I know other people have some questions also, but so if I had a patient and I have a patient with a tryptase levels of 5 to 6, but it wasn't having any particular flare, that doesn't rule them out with having mast cell activation, right? So we should
Right.
we should.
Sorry, go ahead. You have more to the question? Sorry.
Oh, yeah.
Mhm.
So I was just thinking, so basically I should wait to draw when they are having I think a flare that they might potentially have. Okay.
Exactly. So you've hit the nail on the head. So just because you draw the tryptase and it's normal doesn't necessarily mean that they may not have confirmed MCAS. And so to try to confirm it, exactly what you said, you take the baseline one and then you say, when you tell the patient, when you're having, those symptoms that you're attributing to the mass activation, come in, to the lab and get your blood drawn within 4 hours of starting those symptoms. And then you should check what the tryptase is at that point and compare it to the baseline level. And then if it increases by a certain amount, even if both of those normal numbers are still quote unquote in the normal range, if it increases by a certain amount, that could still qualify as confirming mast cell activation syndrome.
Thank you. And I know that Candace said, when would you use biologics? But then she says, question was asked
Oh,
was,
okay, great. Yeah,
uh,
I mean, essentially for me, I like to go, I sort of want to use a latter approach. I prefer starting with the over-the-counter antihistamines to begin with, and then moving to oral medications, things like the Montelukast or Singulair, that kind of stuff, the cromolins and ketotifens first. And then if I get to the point where I've maxed out the oral medications, or if I'm facing a patient who just can't tolerate those medications, then that's when I say, okay, maybe we need to start looking at biologics and other steroid-sparing immune suppressant agents.
I did have a question about the serotonin. So could you explain serotonin? So would that serotonin levels be decreased or elevated in terms of mast cell activation? Would be decreased, right?
So
Or
that's a really good question. And to be honest with you, I don't really know because we don't, in allergy immunology, we don't really follow the serotonin levels since
mm,
it's not exclusively made by the mast cells. We don't look at that as one of our key markers for confirming mast cell activation. So I don't know. I mean,
mm,
my thought would be mast cells can make serotonin, and I
mm.
know that serotonin can be packaged in the granules. So I would assume that it could also be increased if it gets released. But I just don't, we can't be sure whether it's only the mast cells that are making and releasing the serotonin or if other cells are involved. So at least at this point, we don't use that as one of the markers for confirming MCAS.
Thank you. Yeah. And then get Ketotifen plus, could you, I have a patient on Cormalin, but they were interested in starting also on Ketotifen. Are they mutually exclusive or can I use them together?
Yeah, absolutely. So all of the medicines that I went through, some patients prefer one or the other, or they respond better to one or the other, but some patients are on all of them. Like I have some patients, that's the polypharmacy problem, unfortunately. But absolutely, you can use both ketotifen and cromolyn. And so interestingly, when I'm taking care of patients who have mast cell activation in the context of another condition, say like a chronic fatiguing illness or long COVID or a hypermobility syndrome, and it's not necessarily confirmed by biomarkers, I may end up using something like ketotifen because the antihistamine is more of a first generation. It can cross the blood-brain barrier. And in patients who are dealing with symptoms of mast activation and neuropathic type pains, sometimes ketotifen seems to work effectively for them, but then they still need the cromolyn because that seems to work more effectively for their GI tract. So I'll definitely have situations where I use both.
And some people have talked about low dose naltrexone as being a stabilizer too. Do you believe that or no?
So with low dose naltrexone, right now, I don't have enough data or evidence looking at the impact of low dose naltrexone on the mast cell itself yet for me to know specifically if it's acting as a mast cell stabilizer. But I do think it's really useful because I think for sure it works indirectly as a mast cell stabilizer because it seems to be really helpful for chronic pain. And for patients that I take care of who have a lot of pain syndromes, if their pain is not well controlled, again, it's driven by nerves and neurotransmitters. Mast cells can recognize those neurotransmitters that are released by the nerves. That lowers the threshold for the mast cell to be overactive and then results in mast cell activation. And so, at least in my experience, I find that it can be helpful to put patients on low dose naltrexone to manage conditions that lower the threshold for mast cells to go wild.
Yeah, for trouble. Makes sense. And then Candace was mentioning, has there been any newer guidelines for the 2025 consensus?
For consensus. Fantastic question. So actually, that has to happen. So there hasn't been one, but the allergists, I guess, in our national meeting were saying we need to get together and update the guidelines. So you'll definitely find a lot of papers that are out there that are more recent, going through the diagnostic criteria and reviewing that. So those are definitely out there, but they're not yet the official Quad AI allergy immunology consensus guidelines. Those do need to be updated.
Uh, I'm going to give it back to Melissa to.
Okay. All right. Well, we'll give it just one more second to see if anybody has any further questions or comments. And I don't see anything else coming through. Dr. Iweala, thank you so much for joining us. I know it's late where you are, so we really appreciate you taking the time to be here with us today. And to everybody else, thank you for attending today's session. Remember to complete the evaluation form when you receive it. And then if you're interested, our next session is on September the 8th, and topic that day will be something new to our program, which is going to be women's health and long COVID. So everybody have a great rest of your night and hope to see you back sometime.